Hi, my name is student Dr. Gens, and I will be presenting a case on refractory myxedema coma and the current debate in literature surrounding the correct course of treatment. Myxedema coma is a life-threatening complication of severe hypothyroidism, often precipitated by noncompliance with thyroid medication and triggered by a disturbance in body homeostasis with a mortality rate as high as 60%. But what happens if the patient is refractory to treatment? I want to present the case of a 68-year-old female who presented to the emergency department at Pikeville Medical Center with a history of hypothyroidism, hypertension, and severe kidney disease. The patient complained of progressive generalized weakness, fatigue, shortness of breath, headache, periorbital edema, and dysuria. The patient was normothermic, hemodynamically stable, but bradycardic. An EKG was obtained and showed diffuse low precordial voltage and inverted T waves. A chest X-ray was obtained and revealed an enlarged cardiac silhouette. Urinalysis was also significant for urinary tract infection. Laboratory studies resulted in a TSH of 61 and an undetectable free T4. Upon further questioning, it was discovered the patient had been non-compliant with thyroid medication for the past 1.5 years. With immediate concerns for myxedema, the patient was given a 200 microgram bolus of levothyroxine and admitted for further diagnostic studies. Upon admission, the patient was started on 25 micrograms of levothyroxine orally and given IV hydrocortisone in case of adrenal insufficiency. An echocardiogram performed on day 2 revealed moderate pericardial effusion with concerns for pre-tamponade physiology. A pericardiocentesis was ultimately deferred with ongoing treatment of myxedema. A follow-up echocardiogram on day 4 showed minimal change, and the patient was continued to be monitored clinically. Other significant complications arose despite continued increases of levothyroxine and doses of lidothioneine, including hyponatremia on day 3 and altered mentation on day 7. The patient ultimately progressed to myxedema coma. After multiple boluses and increases in doses of levothyroxine and re-addition of lidothioneine, the patient's mentation and clinical symptoms started to improve on days 8 and 9. However, her free T4 and total T3 levels remained low, ultimately deeming her refractory to treatment. The patient was stable, clinically improved, and discharged upon request on day 12 on 100 micrograms of levothyroxine daily. Refractory cases of myxedema are rare, with few reported in literature and several potential contributing factors having been proposed. While the exact cause of her resistance to treatment is unknown, this case brings forth multiple topics of debate surrounding the treatment of myxedema coma. First, intravenous thyroid hormone remains the mainstay treatment. However, levothyroxine versus lidothioneine versus combination therapy remains a controversial topic, with many cases reporting success of levothyroxine alone or with combination therapy. This case provides an interesting contribution as this patient's clinical progress, when compared to her regimen of therapy she received, may suggest that combination therapy had a favorable hand in her clinical improvement. Secondly, the careful management of complications that manifest as a result of myxedema coma has proved to be essential for favorable outcomes. Pericardial effusion with pre-tamponade physiology is a highly reported complication with many modalities of management and different outcomes being reported, both positive and negative. While this patient showed pre-tamponade physiology, she did not meet clinical criteria for tamponade with no pulsus paradoxus, hypotension, or hemodynamic compromise, and so was treated conservatively. Her electrolytes were monitored continuously, and the arising altered mentation was quickly intervened. Many patients see clinical improvement after 3 to 4 days of thyroid hormone replacement. However, this patient did not see improvement until day 8. As the patient was slow to improve clinically and was resistant to treatment, quick intervention of these complications was crucial in preventing further deterioration. While the approach to treating myxedema coma and its complications continues to be a forefront debate in current literature, this case demonstrates the importance of managing life-threatening complications and the use of combination therapy with a positive outcome. Further research needs to be done to ensure the best treatment is given and for positive outcomes in future patients with myxedema coma.